Eat human.
Les humains à leur meilleur.
C'est tu apogeo.
ピーク人間
Okay, everyone, we're back early. The Harvard studies and researchers need debunking. Low-carb diets reduce lifespan. Coconut oil is pure poison. I've had enough of this insanity. Not only is Monsanto funding a lot of their studies, but I think they really believe this vegan stuff, and it's turning them into bad scientists. Good scientists don't have pre-existing beliefs, and they should work to disprove their theories. I think they need some more saturated fat in their diet to help their brains work better. So I got Dr. Bret Scher, who is an intellectual powerhouse, to help debunk their nonsense. He's a cardiologist, a speaker, a podcaster, a scholar, and a gentleman. So let's kick off season 2 with a bang. I've been planning and searching for guests for the past couple of months and have talked to some really interesting people so far. This is going to be good, everyone. Looking forward to it. Don't forget we're on Kickstarter trying to raise some more money for post-production. We need this movie to look as good as all the information that it provides. So don't make me try to edit this myself. Let's rally the troops and make this happen together. All right, we got Dr. Bret Scher here, who's a cardiologist who I got introduced to on some random Twitter thread, I think. And we both realized that we're going to be at the same conference and we both have a podcast. So
it's the power of Twitter, right?
Yeah, that's awesome. So you are a working cardiologist. You are called a low-carb cardiologist. You have a podcast, and I believe you read studies, you keep up with all this kind of thing, right?
Yeah, I mean, you sort of have to. When you're in the world of cardiology and you're trying to make a dent with prevention and lifestyle, you really do have to keep up on all the studies. And the hardest part is filtering out the good stuff from the junk and going past the headlines that you see in the newspapers and the magazines and online, getting past the headlines into the details of the studies to really understand them, because people need a source of authority. They need somewhere to turn to that they can trust to help them interpret these studies. Because, you know, the average person isn't versed in how to read a study and statistics and to look for certain failings of studies and certain strengths of studies. So, and look, nobody's perfect. I'm certainly not perfect at it either. I can admit that right off the bat. But I do my best to keep up on all that and then apply it to my patients. You know, every day, the patient I see in front of me is the most important at that moment. And, you know, I want to have as much in my arsenal that I can to help them. And then the flip side is, you know, people frequently come in with the paper in hand or with the email on their phone saying, what do you think of this study? And, you know, you've got to be up to be able to respond to them.
And random news outlets should not be your primary source of people you trust. You need an authority. And I mean, I guess you have to find a group of people who you trust and rely on them a bit to dissect things.
Yeah, that's such a great point. What is the goal of random news outlets or random media outlets, as you call it? You know, what's the goal? The goal is to get clicks, right? The goal is to get eyeballs onto their webpage so they can sell ads and make money. Now, they can't purposely falsify things and put completely fake things up, but they take things and they twist it in a way that they know is going to make it more attractive to viewers and to get more clicks and get more buzz. I mean, how much buzz has come out of that BBC article and talking about the Lancet study? I think they were the first ones to talk about it. I mean, they've gotten so many hits on their webpage. So that's exactly what they wanted. And they're extremely successful at doing that. But that doesn't mean it paints a true picture. So that's the disconnect we have right now, that where most people get their information, the goals of that information is not to tell the whole story. The goal is to get clicks. And that's just a problem, because what we need as individuals is to get the whole information and get the truth and see how it really applies to us.
Yes, it's misaligned interests that people don't really think about. You know,
absolutely.
What are their interests? What are my interests? They're not aligned. And so obviously we're leading up to something. We're talking about the big study, the low carb and longevity study that almost every news outlet picked up. I'm being hit up by all sides, all my friends texting me about it. They know what I'm doing. They think everything I'm doing is now debunked because one study. It's hilarious. So I'm trying to explain to them science and all of this stuff and how to read a study and how to be a critical thinker in a few text messages, right? So now I got a brilliant guy like Dr. Scher here to help us break it down and figure this out. So
Trying to set someone straight on a couple text messages is a tall order. That's for sure. Just like it is on Twitter, right?
Twitter. Yeah. Basically on Twitter, I'd started saying, come on my podcast. Let's talk. Even, to some vegan person, like, come on. And they never will.
Oh, that's too bad. Open dialogue is what we need. Yeah. So, you look at the study, and this type of thing has happened before. I've written blog posts about it. There was a study in 2010 that was somewhat similar. And all they do is they take a group of people and they just kind of follow them going forward for years and years and years. I think it was 25 years. They just followed them and collected as much data as they can. And then they crunch the data and they say, okay, who had heart attacks, who didn't, who lived, who died, who had, different medical problems. And then they put it all through a big computer and they crunch the data even more, looking for associations or looking for patterns. And then they take those patterns and they can run with them and publish them. But the problem is that there are so many different variables that go along with being people, so many things that data cannot measure. And when you look at this study, there was a very small increased risk of death in those who ate a low carbohydrate diet. And for starters, they define low carbohydrate, what was it, 40% of the calories or 35% of the calories? 37% of calories was low carbohydrate. So compared to the standard American diet, okay, that is low carb. But in the world that we consider low carb and what sort of the healthy low carbers are doing, that is incredibly high carbohydrate diet. Mm-hmm. I love that Dave Feldman posted, when he went on his high carb weight gain experience, he was doing 37%, 40% carbohydrates. That was his high carbohydrate weight gain experience. And that's what they're purporting is a low carb diet. So that's the first fault. But then the second fault is just the quality of the data. So you can observe trends and associations. You can say people who ate low carb had a higher association of death, even though it was a very small increased risk. So there was a higher association, but does that mean it was causative? And that's the main question we have to get at here, because association is interesting, but causative is what we need to act on, because causative means we need to change something we're doing because this is true and fact. But one does not equal the other. Association does not equal causative. And as an example, strength of association is very important. So when you look at smoking, the association was odds ratio of 3.5 or 3.3, I think it was for most studies. In this study, it was 1.18. So the difference between 1.18 and 3.3 is a huge difference, it has to be above 2 to even really start to get interesting. And this was barely above 1. So we're talking about a very small difference. But then the kicker is there's a paragraph right in the article that said at baseline, those who ate low carb diets tended to have a higher body mass index. So they were heavier. They tended to smoke more. They tended to exercise less and have a higher percentage of diabetics. So they were basically much sicker and unhealthier at baseline. And they can try to control for those things with statistics, but you can't completely control for them. And what you definitely can't control for are everything else those people are doing. Because if you are overweight and a smoker, chances are you're doing other things in your life that aren't very healthy as well, that a study cannot even pretend to control for all those things. So right away, it's set up to fail. It's set up to not be able to show that it's the diet that caused it. When you have all these things that make these people sicker, and if they're going to die more frequently, how can you blame it on their diet? So boom, 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 right away. The fact that it wasn't low carb, the fact that it was confounded, it had all these confounding variables, and the quality of the data. In the 25 years, they had 2 data points, twice, where they had to fill out a food frequency questionnaire and said, over the past 6 years, how many times have you eaten eggs? Over the past 6 years, how many times have you eaten vegetables? So that assumes, 1, that it was consistent for the past 6 years, and 2, that you can remember it and accurately report it. And a study like this is just awful. To take that and say, oh yeah, low carb kills is just ridiculous. It boggles my mind. And sorry, I think I'm getting a little carried away here because you can see my emotions coming out.
I love it.
It boggles my mind that people can conclude from a study like this anything. It just does not prove anything. And it's so frustrating that the media outlets want to get clicks, so they report it as if it is proof. And the unsuspecting reader says, oh my goodness, I better stop what I'm doing because I'm going to kill myself. And it's just not the case.
It's so crazy. And news outlets want to get clicks, and they're really savvy about this because they know people want to reinforce their carb addiction. right? That's how I read it too, is where it's you're giving people an excuse to go eat pancakes and bagels and muffins and donuts. That's what people want to hear, right?
Yeah, I mean, that's what people want to hear. And in a way, that could be what the news outlets advertisers want to hear. I don't know if that's the case or not, but you certainly hear stories that if the main advertiser, like the example I hear a lot is if a main advertiser on a news station is a pharmaceutical company, they are not going to run stories that are anti-pharmaceutical companies or anti-prescription drugs. So I don't know, are some of these media outlets have sponsors and ads from Nabisco and Kraft and whoever's selling snacks and carbohydrate foods and pancakes? I don't know the answer to that question, but that's certainly the conspiracy theory. Yeah.
Well, the other conspiracy theory that isn't much of a conspiracy, I think, is that the only reason someone would put out a study like this is because they had an agenda to begin with. Right? The data is so weak and it's just observational study that cannot show causation. Then someone must be trying to do something to even put this out. And it comes from the Harvard School of Public Health, right? And this is notorious for this bias. The many vegetarian researchers there. What do you think?
Oh, yeah, absolutely. Absolutely. I mean, when you look at poor quality observational studies that are being pumped out and that are anti-carb or anti-low carb and pro-vegetarian, most of them are coming from the Harvard School of Public Health and the individual researchers there. And it's a broken record. They keep doing the same thing over and over again because they get a lot of traction out of it. And they have tons of publications that are basically carbon copies of the same thing, the same poor quality data, poor interpretation of the data, blowing the data out of proportion. They're researchers. They depend on getting articles published, getting things in journals, getting more grant money. That's their job. And they're very good at their job. Now, unfortunately, their job is publishing. Their job is not necessarily scientific integrity, I think.
Yeah.
So that's a disconnect there.
And beyond just publishing and doing their work, it seems they have a personal vested interest, right? I mean, what's with Walter Willett and who's this woman, Karen something?
Yeah, I mean, they clearly have a pro-vegetarian, pro-vegan agenda. Yeah, I think that's true. Now, to be fair, though, I mean, to conduct the proper study to be able to prove a low-carb versus a vegan diet with 25-year outcome data, I mean, that is in the hundreds of millions of dollars to perform that study. And takes a very long time and a lot of work. So I guess the argument is, well, we need data to go off of, and this is the best we can do. So we're doing the best we can do. And I find that such a fascinating argument because if the best you can do is incorrect and really poor quality, then maybe we shouldn't be doing it at all. I mean, maybe we shouldn't be using data at all, or this type of data at all, to inform what we should be eating and not eating. I think that's where the breakdown comes, because you could argue that they're not just trying to promote an agenda, but that they're doing their best with the science that they have. That would be best case scenario. I don't necessarily believe that. I think a lot of people don't believe that, but that would be best case scenario. But even then, it still breaks down because it's just so poor quality. And you should be able to identify that as a scientist and a researcher and say, well, hold on. Okay, these sweeping conclusions aren't quite supported by the strength of our data. That's what a scientist should be able to understand about their own data and how it applies to the world around them. But that just doesn't take place. There's a definite disconnect there.
That's a mistake we made in the 60s, 70s, 80s. The whole thing with the low fat. Oh, we'll just recommend a low fat diet. What's the worst that could happen?
Right. What could possibly go wrong? In the MacArthur proceedings, there apparently was a senator who warned about this not being McGovern. Yeah. Sorry, McGovern. Thank you. In the McGovern proceedings, there was a senator who warned that maybe this isn't such a good idea, and someone got up and said, "What could possibly go wrong? There's no way to expect that anything would go wrong with this." So, based on that wonderful assumption, we now have an out of control obesity and diabetes epidemic in this country, thanks to all that, basically.
Yeah, there's so many other things. There's so many ways to break this down. What I like to think about, which you should always look at in a study is, and I thought they're supposed to bring up, is what's the mechanism behind this, right? If you're doing a study, maybe that's just with a randomized control. I don't know, for epidemiology, you don't have to do that. But what's the mechanism? And I don't understand the mechanism of I'm not eating bread and pasta, and that's somehow going to make me live a shorter life.
Yeah, I mean, you asked, are they supposed to? I don't know the answer to that question if they're supposed to or not, but they certainly, whether it's like a requirement or not, but they certainly should. If you want to say, how does my science apply to the world, then absolutely that's the next step you should take and say, what's the mechanism? And I guess that brings up another point too, is quality of food is not measured at all. If all you're measuring is percentages and not quality, I mean, if somebody was eating bread and pasta and bagels as their carbs versus somebody else eating just above ground vegetables for their carbs, that's a big difference. I mean, that's a huge difference, in fact. And that wasn't controlled for at all. So that's another issue with the study. But yeah, absolutely. They should be looking for mechanisms and saying, why could this happen? And how do we apply it to real world scenarios? And that just doesn't happen.
Well, if you're looking like the forest through the trees, if you're just looking in this tiny little bubble, maybe you could say, oh yeah, we saw this and this happened. But if you look at it from even a logical standpoint, or you look at it an evolutionary standpoint, you realize that this doesn't make any sense. I don't know how you can just skip the entire picture here and ignore everything we know about how humans evolved and what we ate and how many millennia we went eating certain diets, and you just throw that out.
From a scientific standpoint, if that doesn't support your theory and if that doesn't support your biases, then it's easy to ignore and throw out because, reality has nothing to do with their study, right? So they could argue, what does evolution have to do with this study we're doing? We're only talking about this study. So, I mean, in a way, you can see why they wouldn't talk about it. But if you say we're only talking about this study, then your data better be pretty sound and pretty solid, which it clearly was not.
Yeah. And then also when you're talking about quality of the foods, what about the quality of fats too? They didn't say if these people are eating avocado oil or some like canola oil or sunflower oil or something.
Yeah. Well, and that's like, to bring in another study that's been passed around a lot lately, the high fat diet causes diabetes was the headline. And then you look at the study and they were mice that were basically force fed a liquid Crisco type fat.
Yeah.
And that gave them diabetes. But the headline had nothing about that. Didn't say it was mice. Didn't say what kind of fat it was. It just said high fat diet causes diabetes. And then, oh my God, I better stop eating fat. This is awful. I don't want diabetes. Okay, don't force feed your mice Crisco and your mice won't get diabetes. That's the only take home we can have from that study. Nothing else. It can go no further than that. Okay, we're all good.
That's so funny. Yeah, and that's similar to what I said to my friends. They said, oh yeah, low carb doesn't work. I said, all this study shows is don't eat a mixed fat and carb diet. That I already knew that. This is what I've been saying. Yeah, you're right. The study showed that don't eat 30%, 37% carb and a bunch of fat. That's terrible. I don't do that. Why would anyone do that?
Yeah, one of the biggest benefits of eating a high-fat diet is having very low insulin, very good insulin sensitivity, and then you can utilize your fat for energy. So if you are eating 37% carbohydrates, you are not utilizing your fat as energy. You are probably not very insulin sensitive. You are still a carb burner. So then if you're eating lots of fat, okay, then that's a different scenario than if you are eating 30, 50, even 75 grams a day of carbs in some people who are very active and very insulin sensitive and metabolically healthy, then you can still be burning fat in those scenarios. And that's a completely different scenario. So it's comparing apples to oranges, to use a carbohydrate analogy.
And yes, metabolic flexibility and fat adaptation. If you're at 37%, you're not fat adapted. That really is unlikely that your body is ready to burn fat and going to do well on that type of diet.
Yeah, very good point.
Speaking of fat, then today I wake up to find this other Harvard researcher talking about saturated fat in coconut oil. So then this other Harvard professor comes out and says coconut oil is pure poison, one of the worst things you can eat. And then later in the article, I go down and the researchers are also quoted as saying, what we do know is that replacing saturated fats with unsaturated fats like vegetable oil, olive oil, and sunflower oil and their spreads has been shown as an effective way to help reduce LDL cholesterol levels. So this would be a healthier choice. So other than olive oil, we're talking about spreads. We're talking about industrial oil spreads.
Doesn't that just make you want to scream when you read that? Oh my God. And it all comes back. I mean, we already did this dance too when the AHA came out with their recommendation against coconut oil. And it all comes down to the same concept. Saturated fat raises cholesterol. High cholesterol must be bad. Therefore, saturated fat is bad. Period. And that is just not a true sequence of statements. That does not hold true. Because the same is true by saying LDL is bad, therefore we can give polyunsaturated fatty acid industrial oils and reduce LDL, and that must be good. That's why all these oils are heart healthy. Oh, but by the way, we're just going to ignore the Minnesota coronary experiment and the Sydney Diet Heart Study that showed, giving these types of oils lowers LDL, but actually raises mortality. We're just going to ignore those and call them heart healthy because they lower LDL. That just doesn't make any sense. And we're still stuck in this era of saturated fat is bad. LDL is the only marker that matters. And that's going to guide our dietary choices. And that's just so short-sighted. And they just have their blinders on and can't see anything outside of that. Rather than saying, let's look at the whole picture. LDL goes up. Oh, but triglycerides go down and HDL goes up and insulin sensitivity improves. What about overall mortality? If you give them a lot of PUFAs, then overall mortality goes up in those other studies. So I don't understand that disconnect. And why are we supporting fake foods, industrial foods, rather than just telling people to eat real foods?
That's back to the logic. The evolution. Everything makes sense under the light of evolution. You have to look at all sides in this, and it doesn't make any sense that we'd recommend these fake foods that we just invented. Just logically, How would that ever be better?
Right. Now, I do have to say one thing about that article about the coconut oil. I think it is true that coconut oil has been promoted as a miracle food, right? It's been, there are blogs saying it'll cure your infections and it'll clear up your skin in 2 days and it'll get rid of everything that ails you. And so I think it has gone a little overboard in saying what a miracle food coconut oil is, but it's a wonderful source of fat. Non-animal fat, by the way. So it's a great source of fat that can be added to your diet if you're looking for other sources of fat. It may not be a miracle food. It can certainly help you get into ketosis and is not going to cure everything about you, but it's a perfectly reasonable source of fat that we should not be trying to get rid of simply because it's a saturated fat. That just doesn't make any sense.
Yeah. And I mean, it also could be bad if you're eating a high carb diet. If you're eating a bunch of processed carbs and grains and then you're adding coconut oil because you think it's good, then you could be in big trouble.
Right. Yeah, that's a great point too, because if your insulin's already high and your sugar's already high and you have plenty of calories and you're just throwing a bunch of fat on top of that, then your body's going to store it. It's not going to burn it. It's just going to store. Yeah. And that's not a good scenario. So absolutely.
Yeah. Any fat in that scenario would be bad, or any excess calories. People need to realize in a low carb, high fat diet, then coconut oil is an excellent choice.
Yeah. Definitely. Just because something's called saturated fat, I mean, the percentages of saturated fat matters and the specific fatty acids also matter. So everything's a little bit different. You can't just lump all fat together. You can't even just lump all polyunsaturated fat together, all monounsaturated fat together, and all saturated fat together. They're not all one thing. They're foods. They're going to affect your body differently depending on what they are and depending on what your body's environment is like you were saying. If you're eating a high carb diet, if you're eating a low carb diet, if you're insulin sensitive, if you're not insulin sensitive, your body's going to react differently to the different foods that you eat.
Mm-hmm. So why don't we go back to LDL a bit? So you're a cardiologist. Actually, tell us about yourself. So I know you're more of a preventative cardiologist, which not many are. That's awesome to hear. So how does that work?
Yeah, I mean, goodness, after spending just so much time in the hospital, taking care of sick patient after sick patient and realizing that 95% of what I see could be completely preventable. It could have been prevented if we could have gotten to these patients 10, 15, 20 years earlier and made interventions in their lifestyle and the way they were living and the things they were doing, could have prevented them from ever getting into the hospital. And it only takes, I guess it takes a longer time for some people than others, but it shouldn't take very long. I've seen this revolving door of people coming in, getting stents, getting their drugs and getting defibrillators and saying, all right, we fixed them. They're all done, until they come back the next time, because it's a systemic disease that is not fixed by one local fix like a stent or a defibrillator or something like that. It's a disease that needs to be treated holistically. And people hate that word holistically. They don't even know what it means anymore. But what it means is you treat the whole person. You treat the whole body. You don't just put a stent in and think you're done. So from the beginning, I knew that was the case. So I I got my fellowship training was a preventative and general cardiology fellowship, which was great. Although interestingly, the structure of it was a pure vegetarian program, which was interesting. And I guess we could get to that. But it was clear in my philosophy that I wanted to prevent things. And the more time I spent in the hospital, even in my current practice, the more time I spend in the hospital, the more frustrated I get because I know we can prevent things. And I vowed to never become that doctor, never become the doctor who says, here's your prescription, eat less, exercise more, see you later. I vowed that I'm going to take the time to really connect with my patients and educate them about what they need to do to improve their life. And that's why I started lowcarbcardiologist.com. And that's why I have my Boundless Health membership program where I do lifestyle consulting and health coaching with people one-on-one, where we could take an hour, we could take 2 hours, we could take 3 hours, whatever it takes to make sure you're getting the information and then test it, right? Everybody needs to become their N of 1 experiment where you follow your lipids and your inflammatory markers and your insulin sensitivity and your PLAC2, your lipid inflammation, and the size and density of your lipids. And you follow all these other markers and your calcium score and your CIMT. We can tell if something is working for you or if it is not. And just because something works for your neighbor or something works for your friend or something works in a certain study doesn't necessarily mean it's going to be the same for you. And oh, by the way, why don't we ask people how they feel? What's their energy like? Is this a diet they can stick with forever? I mean, those are things that we just ignore. And that's something that, looking back on my days of my training where it was a pure vegetarian only intervention, people were sneaking snacks, people were sneaking food, and they were not happy with the diet. Every now and then somebody is, but the majority of them were not happy with that kind of diet and could not stay on it long term. Their energy was low. They didn't feel great. You got to give them something that works. So commonly we say, oh, the patient was non-compliant. The patient just wasn't doing what they were supposed to be doing, because a lot of the times what we give them is not sustainable. So that's something we have to think about too. And that just gets ignored. So these are all the things that come into sort of the mindset of being a preventative cardiologist or being a functional cardiologist. Or I hate those terms because it should just be a cardiologist. This is what doctors and cardiologists should be doing. But instead, we need a special term for it because we're like the black sheep. We're like the unusual cardiologist who thinks about these things and wants to make a difference in this way.
Wow. Yeah. You're the minority. So what do you see? What's the general kind of thing that you see with your patients?
Right now, I see a lot of patients who have gone on a low carb diet and they're afraid because their doctor tells them they're going to have a heart attack and they're going to kill themselves by doing it. And if their LDL goes up and they want to put them on a statin right away. And I see a lot of patients like that to just say, okay, let's take a breath and let's look at this from a broader perspective. All right. And the guidelines and the standard of care, quote unquote, may be to not eat a low carb diet, and it may be to treat any elevated LDL with a statin. But let's investigate this a little bit further and see if you were even represented in any of those trials. And if you were eating a healthy low carb diet and taking care of yourself, then no, you were not represented by any of those trials that form the guidelines. So I see a ton of patients like this. And that's where I say, look, this is where we're outside any guideline, any recommendation. So we have to see what is the best course of action for you. And that's where we'll test with different tools like the calcium score, the carotid intima media thickness testing, and all the blood work, and say, we've got to find something that works for you. So I see a lot of patients like that. I also see people who just want to be healthier and are confused by everything that's out there. And to be honest, I'm a big fan of low carb diets, but for every 3 or 4 people I see, I probably take somebody off a low carb diet because not everybody benefits the same, right? So if your triglycerides are still high and your HDL is still low and your LDL goes up and you didn't get any of the benefits that you thought you were going to get, you either need to stick with it for longer or change something up. And a lot of times that might mean changing your diet. And I think that's perfectly fine to experiment with and measure and see what happens. And I think that's where we sort of have lost our creativity in medicine. Everything is cookbook by the numbers. All right. If you have this disease, we call it this condition or this disease, then we do X, Y, and Z. Okay, here you go. And there's no creativity. There's nothing to say, well, look, you are an individual. And just because what happened with the patient before is similar to what's happening with you doesn't mean the same treatment is going to work. Doesn't mean the same approach is going to work. And that's where we have to think bigger. We have to be more open-minded and try different things. And that's part of the fun of it, right? Working with the patient to find what works for them and then really seeing true success in the long run.
Yeah, it seems like more people are headed towards the not the one size fits all approach, and it's all about personalized medicine, personalized health. And I know that I side with the low carb world, but I'm not like, this is the only way to do it. And this film isn't going to be about this is the only way to do it. I like to look at both sides, or what's the framework here? What's the commonalities between all diets that are good and bad? And do what fits you. I mean, people have different genes. People have different lifestyles. I mean, maybe you just don't like meat, right? Or you just don't like fat. You just can't eat, like, it's gross to you to eat a fatty steak. So let's figure out something that works for you.
Right. I think that's a fantastic point and something we definitely have to consider for each individual. And, I wish that medicine was going more personalized quicker. I think it is going that direction, but I think it's tiptoeing that direction instead of sprinting that direction. And hopefully it will get there a little bit faster. But, all we need to do is look at social media to see just the range of even low carb eating. I mean, I just did a podcast interview with Cardiologist, and she's amazing, a vegan, keto, spine surgeon, type 1 diabetic. I mean, it doesn't get any more interesting than that. And of course, Sean Baker, breaking world records above age 50 and lifting heavier things than most people can ever dream of lifting in their life, and rowing faster than anybody's rowed before, and doing it eating nothing but meat. I mean, who would have ever thought that could even exist? Like, that's unbelievable. Yeah. So just seeing these stories about, how different people thrive in different ways. And we have to be open to that. We can't be so closed-minded to say, nope, there's just one way to do it, and they're outside that way, and it's not going to work.
Well, yeah. And actually, I don't think that the mainstream is going personalized. I should have said that people like Rob Wolf, some of these people are getting, I mean, he's not even a doctor, right? Some of these people are getting into this personalized approach in our kind of circle. But yeah, the mainstream has a lot of work to do before they can even get to this.
Yeah, Rob Wolf's such an interesting guy. I mean, what is that guy? If you hear him talk, you swear he's a doctor. Yeah. And then you hear him talk some more and you swear he's a PhD in anthropology. And then you hear him talk a little bit more and you swear he's a PhD in biochemistry. I mean, that guy, he knows so much, and he's amazing. I every time I hear him talk, I'm like, wait, what is he again? What's his background? Because he's got like 10 different PhDs, it seems like.
And then you hear him talk and he seems like a weightlifting bro.
Yeah, exactly.
He has it all. He's like talking about like MMA or,
Yeah.
It's great. So we kind of brushed over LDL. I wanted to know more about blood markers and atherosclerosis, and just from a cardiologist, what should we be focusing on? What blood markers do we need to worry about? And how do plaques form in arteries and stuff like that?
Yeah, all great questions. And if you go by traditional teaching, LDL causes heart disease. LDL invades perfectly healthy vessel walls and starts depositing plaque and causes heart disease. It's not that simple. That's the way, medicine likes to break it down and teach it in the basics. And it's not like that at all. So LDL is one correlative risk factor for heart disease, which means if you look at studies, just like this diet study we were talking about, you follow people over time, see who has heart disease and who doesn't. Those with higher LDLs tend to be more likely to get heart disease to a small degree. But when you break it down even further, that there's so much more involved. There's measures of inflammation, both systemically, like a CRP, and with a lipid inflammation, whether it's PLA2 or myeloperoxidase, because it's the inflamed plaque that causes heart attacks and death, not just any old plaque, not just any old LDL. Plus, if you look at the sort of biochemistry, how it works, LDL is cleared by LDL receptors, but not taken up by these things called scavenger receptors, which line the endothelial wall. Those take up the oxidized and the modified LDL, and that's the more dangerous version of it. So when you talk about LDL, it's not all LDL are the same. And the basic concept when you talk about evolution is, look, our body would not have created something that's going to kill us, right? Yeah. It's clearly something we are doing to this LDL, to our body's environment. So if we have higher blood sugar, higher insulin levels, higher inflammation, that LDL can get modified, oxidized, and glycated. And that's when it can start to cause trouble. But here's the other kicker, is that there usually has to be some event in the vessel wall in the first place, some sort of injury in the vessel wall, and the LDL responds to injury. The LDL has reparative mechanisms, and it has a role in our immune system. So if there's an injury to your vessel wall, the LDL is going to respond. Now, if that's perfectly healthy LDL, it can get in and out, sort of do its job and get out. If it's oxidized, modified, glycated, it's going to get into the wall and stay in the wall, and that's going to contribute to plaque. So, I mean, I think that's where there's this disconnect about what role LDL plays. So is it important? Sure. But is it everything? Absolutely not. And do we need to know much more about it? Oh, yes, we do. We definitely need to know more about it. So we need to follow the LDL, but put that in a context of what's the HDL and what's the triglycerides. Because those same studies show that if your LDL is 100 and your HDL is 25, you have, so that's a low HDL and a low LDL, you still have a very high risk of cardiovascular disease. In fact, higher than if your LDL was 220 and your HDL was 85, right? So if your LDL is really high, but so is your HDL, your risk is lower than a super low LDL and a low HDL. So that kind of puts it into perspective too. I know that gets confusing without like a graph to look at, but that puts it in perspective that it's not all about the LDL. It's about the environment that the LDL is in. And triglycerides, same thing. The triglyceride to HDL ratio, luckily now people are starting to talk about, but it's such a powerful predictor of cardiovascular disease. It's probably more powerful than LDL alone. And then, beyond that, I'd already mentioned insulin and glucose. Those are so important because nobody measures fasting insulin hardly. And a glucose tolerance test is so important to tell us how insulin sensitive we are. And now, luckily, people are starting to talk about the Kraft test as well, which means doing a glucose tolerance test with an insulin level. And Ira Cummins spent a lot of time kind of promoting that, which is great because now that's being more well known. Those are such important tests to follow. And I already talked about the inflammatory markers and then scanning for disease itself rather than looking for surrogates like a lipid panel. You look for disease itself with a coronary calcium score or looking at with a carotid ultrasound. And you can see, is there plaque there we need to be concerned about? Because that changes things as well. Those are some of the tests I like to follow, varying intervals depending on the person. Are you changing your diet? Are you changing medications? Are you changing the way you exercise or the way you live your life? Or is everything completely stable because you're going to follow things with different frequencies in different people?
Yeah. And the calcium score, I think that's so huge because you're actually seeing the problem. Well, what about the carotid arterial thickness one? Could that vary?
Yeah, so the carotid intima media thickness, CIMT, that's a much better test for quicker follow-up because that you're going to see more acute changes with changes in your lifestyle, and it has no radiation. So you can follow that every 6 months if you want, and it will give you good data. Now, the outcome data for CIMT is not as good as the outcome data for the calcium score, but it's still decent, and it's a completely non-invasive, no radiation test that you can follow that shows acute changes. So a one-time measurement may not be as good as a one-time measurement of a calcium score, but I think the power of the CIMT is following it over time and using that as your more acute marker rather than your long-term marker, which is the calcium score.
Yeah. So you mentioned about the glycated and inflamed LDL. Now, how do those get inflamed?
Yeah, well, that's a good question. So first of all, the glycated means you get like a little glucose molecule stuck on them. And that happens when you have high blood sugar or when the molecules are sticking around in your blood for a much longer period of time. They're not being utilized or cleared. So there's a higher likelihood of getting a glucose molecule stuck on them, getting glycated. And the same for inflammation. If you have lots of reactive oxygen species, you have lots of chronic inflammation and not enough antioxidants to counteract them, if you've sort of overwhelmed your antioxidant capacity, then everything in your blood is going to start to get oxidized and inflamed. And LDL is one of those things. We have a constant battle of inflammation and anti-inflammation going on and have been forever throughout evolution. But this is one of the things where you could say, all right, well, omega-6 fatty acids are healthy to a point. And then when we start mainlining polyunsaturated fatty acids made in a factory somewhere, well, now we're gonna reach that threshold and go well past that threshold and have the pro-inflammatory component overwhelm our anti-inflammatory capacity, and that's when things are going to start to get oxidized and inflamed. LDL being a big component of that.
Yeah, and for anyone who doesn't know, those polyunsaturated fatty acids are those industrial seed oils, which are vegetable oils. So what other types of dietary things can cause this reactive oxygen species and inflammation and stuff like that?
Well, certainly sugars, absolutely. Sugars can. Simple carbohydrates definitely can. And then, the mixed diet that you're talking about, a high carbohydrate and high fat diet is associated with higher levels of inflammation for sure. So any of that combination of that is certainly dangerous. But at the core of it is the sugars and simple carbohydrates.
Yeah. So that's why you promote a low carb diet.
Absolutely. Absolutely. I mean, and it's so amazing because now there's actually great data coming out from Virta Health. Virta is doing such an amazing job treating patients, really helping patients, but also contributing to the literature of high quality studies showing inflammatory markers going down, showing reversal of diabetes, showing improvement of an overall lipid profile. And that's a big reason now why I say this should be standard of care for most people with diabetes, and certainly has to be part of the equation. I've been doing this for 5 years, and it just is so gratifying to see more and more data coming out to support it. So not just if you have diabetes, but if you just want to be healthier, you want to prevent all these chronic diseases, absolutely. I think low carb is going to be a great way for most people to go. Is it going to be everybody? Of course not. But for most people, absolutely. And definitely has to be in the toolbox of every doctor. For a doctor to not even consider it, I think is so short-sighted. It should at least be in the toolbox and something to consider. And that's where I love patients are now educating the doctors about it. The patients are educating themselves. They're showing up to their doctor's office and saying, hey, this is what I did for the past 6 months. Look what happened to my blood work. Look what happened to my waistline, how it went down. Look at how much more energy I have. And hopefully the doctor will be smart enough to pay attention and say, maybe I should start trying that in some people.
Yeah, that seems like a reoccurring theme is a lot of these doctors, Dr. Ted Nyman and, multiple people I talked to, that it started with the patient. So that's awesome. And yeah, we're not saying that overnight all these changes the textbooks are going to be rewritten, but at least it should be an option. That's all we're kind of working for in the short term, right? Just at least recognize this as working.
Yeah. The first step absolutely has to be to acknowledge it and put it in your toolbox. That absolutely has to be the first step. And there are vested interests against it for sure. But on an individual physician level, no individual physician should have a vested interest against their patient getting healthier. And if this is a tool that can help them, then every single individual physician needs to consider it. There's no reason not to, if it's going to help the patient that they are seeing right in front of them at that moment become a healthier person.
Yeah. So what about statins? That's sort of a complicated topic, but everyone thinks it's just automatic, right? Oh, you have high LDL, just take a statin. So what's going on there?
Yeah. Well, it also goes back to, like we talked about the blood marker, LDL is not a perfect measurement, and there's so much more that needs to be considered than just LDL. So remember, LDL is an important part of our body. It is there for a reason, right? We need cholesterol. We need cholesterol all over our body. Every cell membrane needs it. The neurons in our brains need it. LDL has some anti-inflammatory and response properties to it. So lipoproteins transmit triglycerides for fuel, and they bring fat-soluble vitamins all over our bodies. I mean, there are roles for these things. So the thought that we need to reduce them in everybody is completely misguided, because you look at the data, and this is, tricks that they play again in science, especially pharmaceutical sponsored studies, where they say there's a 30% reduction in heart attacks. 30%. That sounds amazing. And then you look at the data, and it went from 1.5% down to whatever 30% of that is. Yeah. But it's ridiculous. It's like less than one absolute percentage point. It's like 0.6 percentage points in a lot of these studies that are groundbreaking, amazing studies that you see all over the headlines, and they say it's going to completely reform care and change the way we're treating people, because now we can be so much more aggressive with these medications for these amazing results. And over 5 years, 0.6% of people had less heart attacks. That's just, again, the disconnect there. And then the other thing these trials do is a lot of them have what's called a run-in period. So you give everybody in the trial a statin for 6 weeks. And those who complain of side effects, you kick them out. And then you randomize everybody. And then you say, look, we only had a 1% incident of side effects. Well, of course, because you kicked out everybody who had the side effects. So it would have been much higher. And it was only a 3-year trial. And now you're saying you're going to put people on these drugs for 10 or 20 years. How do we know they're safe? So again, it's just gotten blown out of proportion. Now, that being said, in somebody who is very high risk, somebody who's already had a heart attack or a stroke or bypass. I actually saw a patient today in my online consulting business where he has familial hypercholesterolemia. He's not even 50 yet, and he's already had a heart attack. And he's asking me about statins. And in that case, yes, I would recommend a statin. Now, it's definitely not all I would recommend. It's one piece of the puzzle. There's so much more important things to be doing with lifestyle, nutrition, exercise, stress management, insulin resistance, all those things. But a statin can be part of that as one piece of lowering your risk. The problem we get into is statins have been blown up to be such great wonder drugs that doctors and patients alike sort of think, all right, here's your statin. You're treated. You're all good. See you later. Oh my God. If I had a nickel for every time someone came in with a heart attack on a statin, it doesn't work that way. It's a multifactorial systemic disease that cannot be treated with one drug, especially a drug that is going to lower your risk of heart attack by 0.6% over 5 years. It's not that good. Now, of course, but like I said, there are some people who are going to benefit. But instead of doing the shotgun approach and saying, let's give it to everybody to lower their LDL as much as possible, why don't we refine their risk a little bit more? So there's the risk calculator, which factors in LDL, HDL, smoking, and diabetes and age. And that's about it. Yeah, so it's a very inadequate risk calculator, but at least it's a step in the right direction to try and say, okay, are you at risk or are you not? But then we should be going further and looking at insulin resistance and looking at calcium scores and CIMTs and inflammatory markers, and then refining their risk score and saying, okay, are you at risk or not? And then saying, okay, well, if we treated 100 people like you with a statin, how many heart attacks would we prevent? Oh, and the other question is how many deaths would we prevent, right? Because that's really what matters. And if you're talking about primary prevention, the answer is none.
Yeah, the mortality is the same.
That's the other... Yeah, that's the other conversation we need to have with our patients more. So it's so much more complicated than just your LDL's high, here's your statin, but yet that's what you're going to get the majority of the time.
Well, it's the classic people just want a pill and then go home. The doctor wants to do that and the patient wants to do that, and they don't want to change their lifestyle. They don't want to change their eating habits. And the old classic, doctor doesn't have time to coach them up on all these things. They don't get paid to do that. So...
Yeah, and most doctors wouldn't know how to anyway, unfortunately, because we're not trained in this in medical school and residency. And the best doctors at guiding people with lifestyle modifications are the ones who took it upon themselves to learn about it and dig deep into it and experiment with it and become experts with it, because it's not by default taught to us. And if it is, it's taught incorrectly anyway. So
opposite.
Not sure that would be very helpful.
Yeah.
Yeah, and you're absolutely right. Look, it's not the doctor's fault. Doctors today are pressured so much by time and by hitting metrics, right? You actually get paid more, or I should say your group gets paid more, because most people are in big groups now. Your group gets paid more by getting people's LDL down and doing it quickly. Whether that helps with heart attacks, whether that helps with strokes and death, that doesn't matter. What matters is that you hit your metric for the month, you get the right percentage of people to their LDL goal, and you're going to get paid more. That's what matters to the bean counters. And gosh, that's not the way it should be. It should be, what is going to help this person in front of me live the best life, the healthiest life that they can live.
It's misaligned incentives. Once again, it's crazy. That seems like the number one thing we should figure out how to do, is how to align incentives for this healthcare. It seems like everyone's best interest, but it's a sort of an impossible thing to figure out, I guess, and try to move.
Well, yeah, I hate that term impossible, but certainly very difficult, because there are so many parts at play. And look, if you have a major medical institution and a big group practice, you need to find a way to make it financially viable so that you can provide care for these people. If you are struggling to pay the bills and keep the lights on, you can't take care of people. So you have to structure it in a way that it's going to make money and be efficient and do an overall good job. Now, me personally, that's not good enough. I want to do a great job for the individual in front of me. And that's very hard to do in contemporary medical practice. And that's why you have to do things like develop an online virtual consulting business where I'm not acting as somebody's physician, but I can give them advice on how to improve their life and improve their lifestyle outside the confines of our medical structure, because it's not being taken care of inside the medical structure. And it's sad. It's sad that we have to go outside of our structure to be able to actually take care of people, but that's the way it's set up. So we just have to be creative and think outside the box about how we're going to help people.
Well, you're doing a good job, man. I like what you're doing. And yeah, you have to go rogue at some point, but I kind of went rogue. I quit my job and started making a documentary and have no money.
Yeah.
So got to go against the grain, which is my pun that I loved.
Yeah, go against the grain, right?
Yeah.
Sorry, I didn't mean to talk over you there. But that's, I'd love to see what you're doing as well. I mean, because how do we get this information out there in a way that people can understand it and digest it and get it to millions and millions of people? And making a good, high quality, respectable documentary like the one you're working on is a great way to do it, because we need to counteract sort of the one-sided, amazingly biased and false documentaries that have already been put out there. I mean, we have to, we need something to counteract that. And so seeing someone like you kind of give up part of your life to do this and dedicate your life to it is amazing. So thank you so much for committing to that.
Well, it's really fun. I'll put it that way. I just got to go hang out with you. I got to hang out with Mark Sisson and Joel Salatin and Nina Teicholz. This is great for me. These are the people that I respect, people doing this work, and I love what they're doing. And I think it's fun. But what else is there other than diet? So heart disease is a multifactorial, very complicated problem, but obviously there's so much more to it than just what we eat. So we talked a lot about what to eat, but what else is there?
Yeah, it's a great question, Brian. We spend so much time talking about nutrition because it's what we do every day, multiple times a day. But you're right, it doesn't stop there, because physical activity is a huge part of it. When you look at the blue zone societies, people where they live the longest, everybody is active. Everybody is moving their body. And that's also something in modern day society that is sort of society is not helping us. In fact, it's hurting us, right? Every building you walk in, the first thing you see is the elevator, and you have to go hunting if you want to find the stairs. The stairs are like hidden somewhere usually. We drive to work, we sit at our desks all day, we drive home, we sit for dinner, we sit on the couch, and we go to bed. We don't have to move our bodies at all during the day. And that is part of what is killing us as well. So being a more active society is absolutely important. So just move your body more. Be an active person is so important. On top of that, if you can, in addition to just being an active person, exercise and do a combination of resistance training and high intensity interval training and cardio training, mix that up, you get all the different benefits of the different areas of fitness. That goes a long way for health as well. And, as people age, it's not just heart disease, it's frailty and this term of sarcopenia, where they're losing muscle and they're becoming weak and falling and breaking their hip. I mean, that's almost a worse way to go than heart disease. So that can be prevented just by doing resistance training. And it doesn't have to be heavy weightlifting, but doing some sort of resistance training to maintain muscle mass. So being active and exercising is so important. And then how we sleep, how we manage our stress, those are so important, because that affects our inflammation, chronic inflammation. It affects the choices we make. How good is our governor and our brain going to be to keep us on track and keep us making the good choices? Well, if we're chronically stressed out and we're not sleeping, well, that's not going to work so well. And that affects our hormone levels, our insulin sensitivity. So we have to pay attention to sleep and stress as well, which is so easy to just sweep under the rug. And then observational studies show that social connections are so important, that people live longer and healthier the more social connections they have. So all these things are our pillars of health that we just don't talk enough about.
Yeah. And with sleep, I never thought much about it, but I read Why We Sleep by Matthew Walker. I don't know if you caught that one, but it's very interesting. He's been on a few podcasts, and I think the most interesting thing is so many people think they're like, oh yeah, I could do fine on 5 hours of sleep. That's just me. And he showed that really that's only a very small fraction, maybe less than 1% of people that actually can run fine on that. Most people are doing a lot of damage to themselves actually by not sleeping. And yeah, just getting that 8 hours is huge. And there's ramifications like Alzheimer's. Your cognitive decline is correlated to sleep and so many other things.
Yeah, there was one study, this is one of my favorite studies, where they purposely sleep deprived people. I haven't looked at it in a while. I think it was 48 or 72 hours that you absolutely could not sleep a wink for 48 or 72 hours. I forget which one it was. And then they had them do a series of cognitive tests and like physical reaction tests just to see how well they were thinking and how well they were reacting. And then they asked them how they did. And they knew. They were like, oh my God, I did so poorly on that. I was just a wreck. I could not concentrate at all, and I was terrible. Then they had people sleep 6 hours a night for, gosh, what was it, like 2 weeks or something like that, but just 6 hours a night, and then had them do the same tests and asked them how they did. And they were like, yeah, I did fine. No problem. I don't think I did anything wrong. Mm-hmm. And their scores were like the same as the people who were sleep deprived. I may have messed up some of the details there because I haven't looked at it in a while, but that was the general concept of the study, which just blew me away because it's not just how you perform, but it's your insight to how you're performing, both mentally and physically. And so sleep is so important for that. There are lots of easy tricks that we can do to help. And the old saying that Steve Jobs and Thomas Edison are the two people who have screwed up our sleep more than anybody, because our tablets and phones that we have right up against our face until the moment we go to bed, and all the artificial light we have blaring at us right until we go to bed, is not supposed to work that way. Our bodies haven't evolved to work that way yet. It's going to take thousands of years of our iPads to evolve there. So we need to be cognizant of that and start to dim the lights and get rid of the screens an hour before bed, not right before bed, but an hour before bed. And that's going to help us reset our sleep cycles and stay consistent with our sleep. And that's going to do nothing but improve our health.
Yeah. And even with the stress, I mean, you can't be thinking about work, that kind of thing when you're trying to go to sleep anyway. And all this stuff, it's probably really obvious to a lot of people listening that it just goes back to ancestral living, right? We didn't have all these lights and iPads. We slept well. We ate, obviously whole foods diet. We exercised. We walked around all day. We lifted things. Everything makes perfect sense when you look at it like that. And that's why things that don't fit into this framework, you should always be suspect of them. And things like a low-fat diet and eating, crackers and Snackwells and rice cakes, just it doesn't make sense. So you got to start questioning these things immediately.
Yeah, that's a great point. Using evolution as a reference is very helpful. Now, we're obviously not going to go back to those times. Our iPads are here to stay. They're not going anywhere. Our lights are here to stay. It's not going anywhere. Our crazy, busy lifestyle is unfortunately probably here to stay. But what we do have to do is try and figure out how to get as many pieces of our life back to the way it was in evolutionary times, back to the way our bodies were designed for and what they were evolved for. So how many pieces of our life can we get back there? And nutrition is one that we absolutely can get back to the way it was and the way it should be. Definitely. And then the others can too. They take a little more work, but we can get there with everything, moving our bodies more, sleeping better, having tight communities. All those things are how we sort of evolved, and we can get back to that type of life.
I agree. And I love this sort of tribe that we're in. Another great book by Sebastian Junger, but our kind of low carb world is a tribe in itself too. And, we kind of all seem to be living under these principles, and it seems to be benefiting everyone. So I think that's a good way to go out on. Thank you so much. And everyone should check out his podcast, Low Carb Cardiologist, your website, lowcarbcardiologist.com. What else?
Yeah, that's probably the best place is the website, the podcast, and then I'm on Twitter at BeSureMD, Facebook page, Low Carb Cardiologist. But that's, the website's probably the best place to start. And I've got a blog and the podcast and a book. The goal is just to get the information out there in as many different ways possible so people can start to internalize this, and something's going to resonate with them and help them improve their health. And that's what we're doing, just trying to get it out there as much as possible.
Yep. And look for him in the film. We got him on film, Dr. Scher himself.
Can't wait to see it come out. So thank you so much for doing that.
Yeah. I will probably see you again soon at some point.
All right. Thanks, Brian.
Thank you. That's all, folks. Order the new shirts on Kickstarter and pre-order the movie there as well. Rate and review this show in the Apple Podcast app. Eat some steak. Follow along on Instagram or Twitter. Read a book in the sun. Tell a friend about the podcast. Do some pull-ups and dips. Tell someone you don't like about the podcast. Get a good night's sleep. Join the Sapient Movement at sapientmovement.com. Make your life less stressful. Smile. Give someone a hug. And come back next week.